Hello, everybody. I am a Professor Dmitrii Maltsev. I am a retina specialist of Kirov Medical Academy, St. Petersburg, and I have more than 2 years experience of working with Solix OCT. And today I'm going to talk about posterior segment optical coherence tomography biomarkers. And I think that everybody knows that OCT done a huge path over the past years, and from the moment of its introduction, it evolved significantly. You can see on this slide first prototype of OCT machine by Swanson in 1993, and first scan with poorly distinguishable retinal structures. And today, the quality of OCT progressed significantly, and we have opportunity to evaluate retina, choroid, optic nerve with high resolution structures of anterior segment in different modes, including OCT angiography in quantitative way, in 3D mode, etc. And all of this, from my point of view, clearly indicates that today OCT is actually a multimodal tool in multimodal diagnosing. And the more we talk about OCT today, the most frequently hear term biomarker, which is referred to a broad category of signs, objective indicators, disorders, which could be evaluated in quantitative and qualitative way reproducibly. This is a very important point. And today we categorize two types of biomarkers: prognostic one, which indicates outcome irrespective of the treatment, and predictive, which indicate response to a particular therapy. And today we're going to talk about both of them. Since many biomarkers were discovered recently, several attempts were done to categorize and stratify them to make the whole variety more appropriate for everyday use. And one of such attempts was done in 2022 in Retina Today. We can see this classification of biomarkers based on the localization. It's logical, but not very useful because it's understandable where biomarker exist. Another attempt was done for categorization of biomarkers in terms of association with systemic disorders such as hypertension, diabetes, or neurological disorders. It's kind of useful, but only summarize systemic disorders, not retinal. A very nice attempt was done in the retina this year, where authors systematized several biomarkers which are can be easily memorized, since they have nice names such as cotton ball, crack sign, onion sign, etc. It's easily to be remembered, and moreover, they're associated with some specific patterns or features which could be distinguishable on OCT images, as you can see on these examples. But only 37 biomarkers were classified in this attempt. I think this is not enough. That's why we made our own attempt to classify OCT biomarkers, and we divide them into big categories: universal and specific. Universal biomarkers include those which associated with a typical pathological process like exudation, neovascularization, ischemia, inflammation, and that's why we can see them in different conditions. But independently on the condition where we see this biomarkers, they indicate the same predictive value. Alternatively, the group of specific biomarkers includes signs which associated with particular disorders or a group of disorders such as AMD, uveitis, pachychoroid conditions, etc. Today we're going to talk mostly about universal biomarker because they're most frequently prevalent in population, and just briefly remember specific in the end of the session. And first, the group, most interesting group, I think, is so-called vascular biomarkers, which caused by ischemia or involution of retinal vessels or disturbance of choroid capillaries microcirculation, because it's also affect choroid. One point before we begin, of course, I think that we all know the most prevalent biomarkers, such as fluid, for example, or central retinal thickness. And I won't discuss them in details. Nevertheless, I briefly mentioned well-known biomarkers just to remember what they are, but mostly focusing on newest categories. So we begin with vascular one. And first one is so-called micro aneurysms or aneurysm at all in general, and they can be easily distinguished, of course, with contrast and geography, but definitely with OCT also, especially with cross-sectional OCT. It is not very distinguishable using OCT-A because blood flow can be turbulent in these structures, and they may generate only weak decorrelation signal. Nevertheless, it also easily displayed on on-fast images, and specifically on deep capillary plexus lab, as you can see on this example, and on both cross-sectional scans and on-fast slabs, we can see the structures as moderately or hyper-reflective structures around foci. And of course, this is quite universal. We can see them in diabetic macular edema, branch retinal vein occlusion, retinal arterial macroaneurysms, and some other, including MACTEL1. And in all of these situations, this feature is associated with the remodeling of retinal microcirculation, some ischemia, and predict risk of exudation. But in terms of treatment, especially I would say laser treatment, when we can target individual macroaneurysms, we can say about positive prognostic value because blocking of exudation from these structures predict visual rehabilitation in patients. The next biomarker, which we now quite good, is the retinal neovascularization, which can be seen on OCT-A. But of course, OCT-A has a limited field of view, and peripheral locations of retinal neovascularization could be missed, and we therefore can miss this future. Nevertheless, it's very important to predict a further fate of patient in need for some treatment like pan-retinal photocoagulation or anti-VEGF therapy. However, we should bear in mind that cross-sectional scans are also very useful to identify these changes, since retinal neovascularization can be easily detected on the retinal surface, as you can see on the bottom image. And to identify these changes on peripheral retina, we use so-called, as we call them, this mode, so-called live OCT mode. And here, as you can see on this example, we just move high-resolution structural scan over a peripheral fundus under the gaze fixation and identify these neovascular changes. And with this approach, we can evaluate almost the entire posterior segment and identify neovascularization with significant level of confidence. Next, very interesting phenomenon which intensely discussed now is so-called retinal ischemic paravascular lesions, which are actually small paracentral middle maculopathy lesions, which we discussed a little bit later. But these small elevations of outer nuclear layer with some thinning of inner nuclear layer are very indicative for subclinical ischemia, not only on ocular level, but mostly on systemic level, since they are strictly associated with cardiovascular disorders, diabetic retinopathy in diabetes mellitus, and unexpectedly a little bit with Behçet disease, since it is associated with arterial occlusions. And these biomarkers could be distinguished not only on cross-sectional OCT, as you can see in this example, but also on fast mode in proximity to retinal arteries as small dark spots. For this imaging modality, we use a synth lab pathing on the level of border between outer nuclear layer and an outer plexiform layer. And this phenomenon is very important since we see these features in patients. We usually recommend them to visit general physician to exclude some cardiovascular disorders. I already told about paracentral acute middle maculopathy, another ischemic phenomenon, but more symptomatic, since the patients with typical paracentral acute middle maculopathy report some complaints and visual deterioration, but nevertheless, this condition is associated with ischemia in inner nuclear layer. It's so-called deep retinal ischemia, and also associated with cardiovascular diseases, retinal vein occlusions, retinal artery occlusions, but also can be idiopathic. They can be seen in acute phase as hyperactivity of inner nuclear layer on fast slabs or structural OCT, and is associated with some hyperperfusion and deep capillary plexus. Interestingly, the association of this phenomenon is indicative for positive prognosis, because the level of ischemia is not very severe. Next form of retinal ischemia, more deep, more severe, is so-called disorganization of retinal inner layer, which include inability to differentiate the borders between several inner retinal layers, as you can see in this example, and it is associated with retinal ischemia in context of retinal vein occlusions, diabetic retinopathy, uveitis, etc. And when this phenomenon touches the central of the macula, it is associated with very limited visual rehabilitation during anti-VEGF therapy or any other treatment. And next biomarker, also ischemic, but another form of isolated retinal ischemia, is ischemia of retinal nerve fiber layer, or we also know these changes as cotton wool spots, which are associated with diabetes, diabetic retinopathy, retinal vein occlusions, and cardiovascular morbidity. And after resolution of this hyperreflective foci in the inner retina, we can observe a loss of retinal nerve fiber layer, these defects on fast mode, and thinning on cross-sectional scans. This is just another form of isolated retinal ischemia. And all these three forms, drill, palm, and retinal nerve fiber layer defects, are forms which are associated with damage of the retina to different level of retinal microcirculation. Another form of ischemic or dyscirculatory condition is a so-called angular sign of Henle layer hyperreflectivity, which previously was called acute macular neuroretinopathy, and this term is still correct, but angular sign of hyperreflectivity is just a phenomenon, imaging phenomenon, not a condition, since it very common for different situations, including posterior uveitis, retinal vein occlusions, and quite typical for ocular trauma. And as you can see on this slide, it is associated with hyperreflectivity on the level of autonuclear layer and hyperperfusion on the level of choroid capillaries. This is example of MPP. And in another situation of laser injury to the macula, we can see this angular sign very easily, since it is associated with damage to the Henle fiber layers, which have this horizontal way in the autonuclear layer. They begin from vertical line and then goes horizontally. That's why this term called angular sign. And that's all what I'd like to say about vascular biomarkers. And next we have to go to exudative, since they are associated with leakage, hemorrhages, and accumulation of fluid, or with the risk of such accumulation. I think that we all know very well different types of fluid, including subretinal fluid, fluid under retinal pigment epithelium, and intraretinal fluid, which is presented here in the minimum amount, but nevertheless it's very important. And all of these types of fluid represent a very, very common pathological process of exudation, which can be found in age-related macular degeneration, central serous retinal macroaneurysm, diabetes, and occlusions. And despite appearance of fluid and different type of fluid have different prognostic value in different disorders. In general, persistence of fluid is not good for the retina, and over time, the retina which experienced action of fluid became atrophic and lost its function. That's why in long-term way, this is negative biomarker. But when we talk about treatment, we may hope that resolution of fluid can be associated with visual restoration of patient, and therefore short-term presence of fluid and amount of fluid is in general a positive prognostic biomarker, because the more fluid patient has, the more visual improvement we can expect. Another phenomenon which is strictly associated with exudation is especially with presence of subretinal fluid, is so-called double layer, and we can see this phenomena as a separation of retinal pigment epithelium from Bruch's membrane, with appearance of some hyperreflective material between these two structures, and this material represents choroidal neovascularization type 1, which in many cases can be revealed by OCT in the presence of double layer sign. It's specific for AMD, central series, but can be idiopathic, and in general it is quite a common phenomenon. From its association with exudation, it has a negative prognostic value, but there are two separate situations regarding this future. First one, when we can see double layer with very weak or no flow signals, you can see on this example of chronic central series. Nevertheless, it should not be recognized as the absence of CNV. CNV is present, but it's not active, since blood flow is very weak. And in case of CCR, in such case, we may talk about dual source of exudation, not only from CNV, which is more or less non-exudative, but rather from the choroid, as it typically can be seen in central series. Another situation which is which can be differentiated as another biomarker, so-called non-exudative double layer or non-exudative MNV, which can be seen in the context of AMD or CSCR, or can be idiopathic. It is the same double layer and very nicely imaged neovascularization on OCT-A, but no fluid on cross sections, despite long observational period, and that's why these situations called non-exudative. And in general, if no exudation appears in the future, we may consider this phenomenon as more or less positive. Because the structures, this non-exudative MNV, maintain functioning of outer retina and maintain its in good condition for a long period of time if no exudation appears. Therefore, it more or less positive. A very important group of biomarkers, which I think is a key for correct one of the keys for correct indication of anti-VEGF therapy is subretinal hyperreflective material, because it can be seen in two forms, exudative and non-exudative. And first one, exudative form, which include fibrin, type 2 MNV, and some subretinal hemorrhages. And if fibrin is more or less neutral in terms of prognosis, also it can be associated with subretinal fibrosis. But type 2 MNV and hemorrhages were strictly associated with the risk of subretinal fibrosis and negative outcome. Therefore, in general, exudative subretinal hyperreflective material is of negative prognostic value. And it can be seen in AMD, central serous, and retinal macroaneurysm, where it is a hemorrhage. Next group of biomarkers which we have to discuss today is so-called neurodegenerative biomarkers. They're quite closely related to exudative because it can be mismatched. But these biomarkers are associated with loss of retinal tissue or a particular layer of a tissue retina. And first one, very important, very common, which has a very strong negative predictive value in almost all retinal conditions, from CSR to retinal dystrophies, is ellipsoid zone disruption. And as you can see on this example, that means loss of photoreceptors on some length of the retina, and denudation of outer limiting membrane, as you can see on this example. Definitely where no photoreceptors are presented, there is no vision. But another very close phenomenon, which can be seen in more mild situation with potential to visual rehabilitation, is photoreceptor outer segment thinning. As you can see on this example, it is associated with thinning of this outermost retinal layer, and it is a frequent finding in central serous, and can be seen also in neovascular AMD. But a very interesting point that in central serous, this thinning of photoreceptors is associated with the site of the leakage. As you can see in this example, on fast mode, the thinning of photoreceptors are represented by this dark area. It is nicely correspond to the leakage point. It can help for non-invasive identification of leakage in these patients. But we nevertheless should bear in mind that this thinning of photoreceptors is not just vanishing or wash out of outer segments by the leakage. It is the mildest form of outer retinal atrophy, since it is strictly associated with the thinning of outer nuclear layer independently on the if subretinal fluid present or not. You can see the thinning even after resolution of fluid, and there's correlation between photoreceptor loss and outer nuclear layer thinning is quite strong. Another point which we have to bear in mind when considering the loss of photoreceptors, it is the fact that they interact with the scanning beam, and if we have some loss of photoreceptors, it definitely leads to hyper transmission of scanning beam to the retinal pigment epithelium and to the choroid. And in such situation, we can see some enhancement of flow signal from the choroid capillaries, and should not misinterpret this situation as, for example, some true flow signal or some CNV. Next point which we have to discuss is so-called outer foveal microdefect. This quite common situation in patients with ocular trauma or after tractions, where we can see this small loss of photoreceptors in the very center of the fovea. Unfortunately, this situation is very stable, can be evaluated by patients as difficult with reading or discriminating small objects. That shouldn't be interpreted as any other phenomenon like cavitations or photoreceptor erosion. A very interesting phenomenon of non-exudative neurodegenerative situation is inner nuclear layer microcyst, is a subtype of fluid in the middle of the retina, as you can see on this example in the inner nuclear layer, which can be also depicted on structural on-fast OCT. And it is associated with the degeneration of this layer, loss of neurons, and is frequently seen in advanced open-angle glaucoma, multiple sclerosis, or in this situation after vitrectomy. And of course, since it's neurodegenerative, it is associated with negative prognosis and should not be misinterpreted as macular edema. It should not be treated with anti-VEGF drugs or steroids. Next, a very well-known situation of non-exudative fluid associated with neurodegeneration is cavitational anomalies in MACTEL-2, which can be also seen in some other situations like advanced AMD. And you can see these spaces of irregular shape, not restricted by a particular retinal layer, but crossing different layers. This is not usual for true intraretinal fluid, and this is very specific for MACTEL-2 and associated with neurodegeneration, but and in general with negative prognosis, but visual deterioration in these patients are usually quite mild. But very important, do not misinterpret this situation as fluid, which requires active actions like intravitreal therapy. And another very well-known biomarker, autoretinal tubulations, which also is neurodegenerative in nature and can simulate intraretinal fluid, but should not be treated since it is very resistant to anti-VEGF therapy and in general is associated with negative outcome of patients which are in late stage of AMD or retinal dystrophies. And this situation where we can see this hyperreflective cavities in the autoretina outlined by hyperreflective border, and we can easily see these tubules on fast mode in the autoretina. This is a very useful imaging modality to identify autoretinal tubulations, which which have this amoeboid form. Also, very important phenomena for predictions of visual outcomes, especially in patients with AMD and diabetes, these large intraretinal cysts in the middle of the macula. Despite their associated with active exudation, the treatment in such case is not very useful because these large cysts are associated with damage to the neuronal links between inner and outer retina, and therefore, even after anatomic restoration of the retina, we may expect only a limited visual rehabilitation. And interestingly, this biomarker is also associated with presence some central ischemia and drill. When this large cyst is gone, the inner retinal layers are typically undifferentiated in the retina. And threshold to distinguish this large cyst from middle or small cyst is 400 micrometers, which we can measure on horizontal dimensions you can see on this example. Next group of retinal pigment epithelium degenerative biomarkers include those which are associated with loss or dysfunction of retinal pigment epithelium of different degrees. And a very mild form of this retinal pigment epithelium damage is RPE hypertransmission, which can be seen in the choroid at these hyperreflective lines, which are caused by better permeability of scanning beam through the damaged RPE, and this is very indicative for RPE damage, but it is not easy to evaluate the severity of this damage. And here, en face mode, so-called OCT translamination can be very helpful. For this mode, we use 200 micrometers slab placed in the outer choroid and the choroidoscleral junction, which accumulate all hypertransmission signal and depict them in on-face image. As you can see on this example, it is very highly correlate with fluorescein angiography and contrast autofluorescence mode. Another situation where we can see, in contrast to previous biomarker, hypertransmission, where RP migrates from the RP layer to the outer retina, and this situation is quite typical for dry AMD over the peaks of large drusenoid detachments. And since this is associated with dry AMD, and since it is associated with destruction of this large drusen, it has in general negative prognostic value. When we see this RP migration, we can predict destruction of this large drusen and formation of geographic atrophy. This biomarker can be distinguished not only on structural OCT, but also on a very nice, I personally believe, so-called pseudo-SLO mode on Solix. As you can see on this example, it is indicative for accumulation of pigments on the top of this drusenoid detachment, and as already said, indicative for coming destruction of this structure. I already told about hyper-reflective material under the retina in exudative group of biomarker, but it also can be non-exudative. And when we talk about non-exudative hyperreflective material, mostly we talk about vitelliform substances which accumulates from malfunctioning of RP and in inherited conditions like Best disease, or in some other situation like central serous or AMD, where a function of RP is damaged. And since the easiest way to distinguish vitelliform material is fundus autofluorescence, some OCT features can be helpful to differentiate them, this material from exudative one. And these features are homogeneity, as you can see it, very homogeneous, and reduce choroidal hypertransmission, which can be identified with OCT transillumination, because again, this material as a product of photoreceptor autosegment interact with scanning beam more than fibrin, for example. And gravitational separation, as you can see on the left slide, is also very indicative for non-exudative nature of subretinal hyperreflective material. Next group of very important biomarkers, so-called inflammatory, associated with inflammation, but not in terms of uveitis, which is definitely present, but associated with presence of inflammation in primarily non-inflammatory retinal disorders, such as diabetes or retinal vein occlusions. And first one, which we know very well, it is intraretinal hyperreflective foci, which can be activated macrophages if they're small and have no shadowing effect, or it can be hard exudates where it's more large and have some hypertransmission, some shadows below them. Both this situation more or less associated with inflammatory pathway activation, but I personally believe that the small hyperreflective foci in the early stage of retinal vein occlusion, like in several days after onset, are truly activated glia or macrophages, and they're way smaller than hard exudates. You can see this example on cross-sectional scan on fast mode. This is another example of this activated cells, very small intraretinal hyperreflective foci in different retinal layers, where we can expect that this is not hard exudate because too small time period passed after onset of the disease. You can see this central retinal vein occlusion. Another location of hyperreflective foci, very classical, is anterior chamber, but we cannot distinguish small cells, and especially in situation where we do not expect them. And nevertheless, anterior segment OCT is very sensitive to detect even few cells in the anterior chamber, and three-dimensional mode is very useful for this indication, as you can see in this example of patients with some macular edema. Next point where we can also find this small hyperreflective foci is posterior chamber, which is unavailable for evaluation with a majority of OCT, except for Solix, where we can evaluate this chamber and identify this foci here, even if they're not presented in the anterior chamber. And in this case, they're associated with posterior segment changes, including this uveitic edema, and this presence of cells indicates activity of inflammation, even if the cells are not presented in any other parts of anterior or posterior segment. You can see the vitreous is quite clear here. Next location of intraretinal hyperreflective foci is vitreous, and we can easily detect them with cross-sectional scans and preretinal vitreous layers as small hyperreflective foci. But the most appropriate way, I believe, to quantify this foci is three-dimensional mode on the top image, where we can not only see this foci, but also evaluate their distribution in general amount. And we have to bear in mind that this biomarker is indicative not only for inflammation, but also for neovascular complication in terms of appearance of blood component or it can be also seen in erythematogenous situations where blood or some melanin cells, some melanin particles came to the vitreous. Nevertheless, we have to be more cautious if we see these particles in the retinal vitreous and evaluate patients deeply. A very interesting biomarker, which was recently described, so-called macrophage-like cells on the inner retinal surface, which detected by image averaging in OCT scans, which I think you remember, compiled several singular three-dimensional scans or with through image averaging. These cells appears in healthy eyes, but change their number in retinal vein occlusion, diabetic macular edema, some other conditions, including uveitis, and they are very characteristic, for example, for mutes, where the number increase several times. And we have to remember that the best way to display these cells is a very thin flap on the inner retinal surface, just 10 micrometers on the very inner border of the retina. And as I already said, the best way also to average several image, the opportunity which Solix has, it can average four 3 millimeters OCTA scans, and you can see the beautiful quality of the image which resulted from this image averaging. Every cell is clearly visible, and we can identify the stellate morphology typical for macrophages. And another situation where this phenomenon could be helpful is retinal vein occlusions, and in situation where we can see the huge number of the cells, as you can see on this slide, is associated with some inflammation. Some other features such as subretinal fluid are also present here. And this is a situation of papulophlebitis, and it is nicely respond to intraocular steroids instead of anti-VEGF therapy. This can be helpful in differentiating treatment mode for these patients. And the last group of biomarkers which we discussed today, very interesting since it is associated with the mechanical changes of the retina and are typical for surgical conditions since they are caused by tractional forces or tectonic forces applied to the retina. And first one is so-called fingerprint retinal pattern, which represent as this circular lines around the center of the macula and correspond to this brush sign on outer nuclear layer. And this can be seen on OCT, on fast OCT and cross-sectional OCT in cases of epiretinal membrane, posterior segment neoplasm, optic disc edema, and even sometimes on central serous. In other words, in all cases where we can observe some displacement of the retina, especially different retinal layers, one from another. In any way, it is indicative for tangential or tectonic forces, but should not be mismatched with directional artifacts. The fact that this situation is caused by tractions, supported by this case, you can see a patient with macular edema, very strong tangential traction, and appearance of fingerprint pattern. And despite it is hard to find the cause of this edema, we can see that after release of this traction, the edema gone together with this fingerprint pattern. These cases, as many other, support our suggestion that if we see this pattern, we should check for the presence of tangential forces, even if they are not obvious. Another surgical phenomenon which we frequently see in epiretinal membranes is so-called cotton ball sign. It is accumulation of hyperreflective material in the very middle of the fovea, unless it is not associated with significant visual deterioration. It may predict future decline in visual acuity if the situation won't improve after surgery. But very important point, it should be differentiated from subretinal hyperreflective material and in general indicative for needing surgery. Outretinal corrugation is a specific phenomenon for retinal detachment situations, but of different causes, and indicate some edema in the photoreceptor layer and some stiffness of more inner retinal layer, autonocular layer, for example. And that's why these corrugations appear. And since this nature, the predictive value of this phenomenon is negative. It reflects switch retinal detachment from stage 3A to 3B, and mean that visual deterioration visual rehabilitation may be not so good after retinal detachment surgery as we would like to have. And anyway, it should be not misinterpreted as a simple thickening of photoreceptor outer segment layer, since again, this indicative for limited visual rehabilitation. A very practical important biomarker in surgical pathology is residual subretinal fluid, which can be seen in situation where retina was detached at baseline or during surgery, like in postoperative situation, like macular hole. In all of these cases, it shouldn't be interpreted as active detachment, especially where this fluid occupies large areas. It can be misinterpreted as a leak from not blocked break. But this outretinal hyperreflectivity, which can be seen on cross-sectional scan, is highly indicative for residual character of this fluid, because if the actual detachment is present, this layer is not highly reflective. And in general, this situation is associated with positive prognosis, because this fluid will gone in future without visual deterioration. But also it should be differentiated from some situations associated with exudation, such as CCR or Phoktakana-Yagi. Another phenomenon which can be seen in patients with epiretinal membrane high myopia or vitreomacular tractions is paravascular inner retinal defects. As you can see on this example, these hyperreflective spaces may appear nearby large retinal vessels, mostly veins, and this indicative for tangential tractions, which are drawing the retina from the vessels and create these spaces. The prognostic value of this situation is not known, but this is highly indicative for tractional forces in remodeling of posterior eye segments, such as high myopia, and shouldn't be misinterpreted of high as a retinoschisis or just some exudation. And in final few slides, I'd like to mention briefly specific biomarkers, which definitely requires another meeting, which are associated with particular conditions or small groups, or not small, like pachychoroid, it's quite broad, a group of disorders. And indeed, here we can define several groups associated with dry AMD, which include different types of drusen, soft drusen, pseudodrusen, ghost drusen, and some other like onion sign, which can simulate fluid and activity, but non-active in fact. Neovascular AMD is associated with different subtypes of activity, such as ballade, bacillary layer detachment, suprachoroidal cleft, bridge-shaped fluid, which have different prognosis in terms of visual outcome. Pachychoroid definitely has its own group of biomarkers, mostly referred to the status of choroidal vascular anatomy. Myopia, it is associated with lacquer cracks, peripapillary cavitation, perforating scleral vessels, a very interesting phenomenon which may predict the occurrence of CNV. Optic nerve is another field where we can find avoid masses, buried drusen, some degenerative changes, retinal dystrophies, mostly inherited conditions, including subretinal pillar, RCA phenomenon, or recently described hyperreflective line of GCC layer in retinitis pigmentosa. Uveitis, a very broad subcategory, which include the chrysanthemum phenotype in peak or other posterior uveitis, Corellis plex, Darwin-Fox nodal, and many anatomical phenomena, mostly undetermined value or with neutral values, such as dome-shaped macula or Fovell-Muller cells. I think all of them deserve many attention, but unfortunately we can't pay this attention now. In conclusion, I think that abundance of posterior segment biomarkers allowed a comprehensive approach to diagnosing, monitoring, and prediction of retinal disorders. All of this definitely became possible with progressive OCT device and incorporating options to display posterior segment with OCT-A and en-face mode, image averaging, some other technologies. And I think that important point which we, as the retinal specialists, missed is evaluation of anterior segment, where we can find many biomarkers which are referred to the status of the posterior segment, such as anterior chamber foci, but we can find much more, such as status of suprachoroidal space, which can be detected by anterior segment OCT. And I think that the role of anterior segment changes in posterior segment disorders is kind of underevaluated. And that's why high quality anterior segment OCT is very important from my point of view for retinal specialists too. And that's why these devices which we use, such as Solix, should include this mode. Thank you for your kind attention. If you have any questions, I'm ready to answer it. Thank you.